The title that's been given to me is the role of genetic testing in peripartum cardiomyopathy. So my background, just to clarify, I'm an imaging cardiologist with a particular interest in heart muscle disease. I work closely with Will Bradlow, who set up the service effectively about 10 years ago now, but I've been in a consultant post now for just over 4 years. And my training was in Birmingham, and I did a year at the Brompton prior to starting as a consultant here. So what am I going to cover? I'm going to tell you obviously what peripartum cardiomyopathy is. I'm going to discuss how common a condition it is, and specifically cover the role of genetics, which I think is important to get across. So in terms of where to get information, I'm sure many of you are familiar with the Cardiomyopathy UK website, otherwise you wouldn't be here, but it's just to say there is a fantastic fact sheet already available, which covers everything you could want to know really about peripartum cardiomyopathy. And I'm not going to dwell on this further, but that's easily accessible on the website for those of you that haven't already read it. But just to clarify what peripartum cardiomyopathy means, it's fancy medical terminology, but essentially peripartum just is fancy Latin for saying around the time of pregnancy, and cardiomyopathy, as you know, is a heart muscle condition. It was previously defined by quite set criteria in terms of timing. So it had to be a diagnosis that was made in the last month of pregnancy up to 5 months postpartum, so 5 months after delivering the baby. But actually that has been relaxed a little bit more. So the 2010 Heart Failure Association, the European Society of Cardiology, revised the definition some years ago and call it this. So an idiopathic just is, again, fancy medical talk for we don't have a clear cause, so unknown cause of cardiomyopathy presenting with heart failure, secondary to left ventricular systolic dysfunction. So systolic dysfunction, again, is just a term that we would use for the pump not pumping as well as we'd like. And they don't specify timing quite so much, but generally it tends to present towards the end of pregnancy. Most women that are diagnosed with peripartum cardiomyopathy usually are diagnosed with heart failure after the delivery of the baby, but not always. And sometimes it's picked up in people usually in the last trimester. And this is the important bit of the definition, when no other cause of heart failure is found. So this is really a diagnosis of exclusion. So it's a form, if you like, of dilated cardiomyopathy, which many of you may have heard of as well. But dilated cardiomyopathy can mean a lot because there's a lot of etiologies, and peripartum cardiomyopathy is just one form of dilated cardiomyopathy. What's interesting is actually if you look at the registry studies around this condition, depending on where you are in the world, there are different rates diagnosed. So if you happen to live in Nigeria, actually nearly 1 in 100 of all live births are complicated by peripartum cardiomyopathy, which is interesting. And that probably reflects the African American descent. And certainly we know being African American or Afro-Caribbean is a risk factor for this condition. But the rate varies. So in the US, which I guess is not as similar to us in terms of demographic, or relatively similar, looking at about 1 in 1,000 cases. So pretty rare, but not that rare. And for some reason in Japan, it's very rarely diagnosed. I'm not quite sure why that would be. In terms of the temporal trend, I've talked about risk factors for Afro-Caribbeans. This is x-axis. This is going across in years from 2004 to 2011. This was taken from a very nice review article that's freely accessible from the BMJ, published a few years ago now. And this is the incidence rate, so number of new diagnoses for every 10,000 live births. And you can see it's far more common in more elderly pregnant ladies. So the higher risk group are those patients, those ladies that are pregnant between the ages of 40 and 54, far more commonly diagnosed than younger mums. So I've already touched on this. What are the risk factors for developing it? Well, ethnicity is one. Patients often will have preeclampsia, and preeclampsia is far more common than peripartum cardiomyopathy. Preeclampsia is a condition that a lot of women suffer with towards the end of pregnancy. We know that it's associated with worse cardiovascular outcomes, and there's a lot of research going on into why that is. But preeclampsia is a condition where patients develop usually wee in their urine towards the end of pregnancy, and they also have very, very difficult to control blood pressure. And if it's really left untreated, they can very occasionally fit, which is why it's called preeclampsia. So eclampsia is just a term for fitting. So if you have bad enough blood pressure in sort of 220 systolic and you leave it long enough, then you can fit. That's why that term is there. Multi-gestational, so if you've got twins, triplets, or even more fetuses in the tummy, then you're at greater risk. Older maternal age we've talked about, and this is really key. So whenever I see anyone that's diagnosed around time of pregnancy, I think this is a really key question to ask. Have you got any first degree relatives or more distant relatives for that matter that have been affected by heart pump disorders that haven't been clearly worked up? The actual science behind why patients develop this condition is complex, and I don't want to dwell on it, but in essence, we don't really understand the true biology, but there are some theories behind this. There are certainly hormonal events that happen during pregnancy, towards the end of pregnancy, and we think that prolactin is important. That's a hormone that's produced in the pituitary gland, which is a gland up in your brain. There are effects on the endothelium, so all of our blood vessels are lined by endothelium, and when you have something called endothelial dysfunction, that can cause inflammation and problems. And there are also factors produced from within the placenta towards the end of pregnancy, things like vascular endothelial growth factor and other proteins you don't need to know the names of, but essentially there are proteins being secreted into the bloodstream, and with increased stress. And what's important to note is that not all patients clearly develop this. So why do some? Well, we think there is a genetic susceptibility. So much like with other conditions, and that brings me to the next slide, we think that pregnancy probably represents what we call a second hit. So this is not dissimilar to some patients who've had chemotherapy and developed problems with heart pump function. There's probably an underlying genetic susceptibility. That may be one gene, it may be more than one gene that's involved. And then you throw in other things into the mix, whether it's infection, inflammatory disorders, chemotherapy, alcohol, and pregnancy can be just one of those things that can tip the balance and then result in an abnormal, what we call phenotype, so an abnormal heart with an abnormal pump function. And there's a whole host of genes that have been implicated, but probably the most common gene that we associate, certainly in the literature, with peripartum cardiomyopathy is the titin gene, and I'll talk to you a bit more about that in a moment. But there are others. There are I've had patients presenting with peripartum cardiomyopathy, and we've subsequently diagnosed with lamin cardiomyopathy, which is another gene that can be associated with it, and there are a whole host of others. So this was a big paper that was published in the New England Journal of Medicine. If you're a medic, publishing in the New England Journal of Medicine is your #1 aim in life if you're an academic, because this is the biggest journal and the most widely respected. So this was a big deal when it was published some time ago now, back in 2017, by James Ware and colleagues. James Ware is a consultant cardiologist, academic based at the Brompton, and this was a multinational, multi-registry study. So they took 6 cohorts of patients with a mixture of peripartum cardiomyopathy and dilated cardiomyopathies, and they basically performed genetic testing in all these patients. So took a blood test and had a look, and what they demonstrated was that actually as many as 1 in 7 patients had a typing abnormality. So that's a fancy terminology as a causative genetic variant, whether that be a likely pathogenic or a pathogenic variant. So that's where you find a typing error in a gene that codes for the abnormal titin protein. And the majority of those variants were in titin, as I say. So titin is the largest protein in the human body. It's a critical component of sarcomeres. So sarcomeres are the heart muscle cells, and it's important in both cardiac and in skeletal muscle function. And what they showed really was that this was probably more prevalent than we'd first appreciated. So this is going back 6 years. There's a really useful what's called state-of-the-art review that was published in JACC. So JACC is Journal of American College of Cardiology, and this is freely available for those of you that want to read up more around this condition. This was published, I think, in 2020, and it just highlights some of the things that we think about as medics when we're looking at patients. So we've talked about the definition and the risk factors. Most patients present with heart failure symptoms, and that can be really, really difficult for clinicians, because what do most pregnant ladies become towards the end of pregnancy? Well, they invariably develop ankle swelling to a degree. They invariably become a bit breathless. And that's not surprising because they're carrying around an extra baby, and they often can, and a lot of the signs can mimic heart failure. So it becomes a difficult diagnosis to make in some. And essentially what you really need to make a diagnosis is a high index of suspicion. So you need a clinician that's wary, and then ultimately an echocardiogram. So an echo, which you'll all be familiar with, is a jelly test to look at the heart pump function. And classically, you need an ejection fraction of less than 45%. I don't quite know why they've chosen 45%, but that's the cutoff for this diagnosis. And during pregnancy, what can you do? Well, conventional heart failure therapy, effectively. So most ladies, while pregnant, can still take beta blockers safely. There's a small risk of growing slightly smaller babies on beta blockers, but it's felt to be safe. Patients can be given loop diuretics, so that's things like furosemide, and nitrates. And digoxin is also safe, as is low molecular weight heparin. But you have to withdraw ACE inhibitors and angiotensin receptor blockers, and that includes Entresto for anyone that's on Entresto, which is sacubitril valsartan combination that some patients will be on with dilated cardiomyopathy. So that's a concern. If you've got a dilated cardiomyopathy and you become pregnant, there are certain drugs that you would need to stop, and ideally we'd know about that beforehand. In terms of delivery, in any patient with abnormal heart pump function, we need to liaise closely with the cardio-obstetrics team, and we have specific teams. Sometimes that can be managed locally in DGHs, but sometimes it's best dealt with in centres such as Birmingham Women's Hospital, where we bring our highest risk pregnancies. And then following pregnancy, there's other important things to be aware of. You know, some patients we sometimes consider putting devices in, particularly if there's severe LV dysfunction. The importance of contraception is really key, because getting pregnant again quickly without time to allow the heart to recover is an issue, and not something that we want. And generally, patients unsurprisingly do worse if they fail to restore normal LV function, so they continue to have a reduced ejection fraction. And those patients who have a dilated baggy heart, so the heart size is bigger as well as not pumping well, and those are the patients that tend to do less well. So this is taken from the same review. Sorry, this is all a bit small. It probably doesn't project terribly well, particularly with the way my IT is set up. But this is what I've said already, essentially. It's just to be aware that anything in green is okay in pregnancy. So loop diuretics, beta blockers, hydralazine, and nitrates. Digoxin are felt to be safe, but ACE inhibitors, ARB, aldosterone receptor antagonists, so that's things like spironolactone, can't be continued during pregnancy. Entresto we've talked about. Ivabradine, not used commonly, but some patients will be on, again, isn't felt to be safe. We depends a little bit on where you are, but most patients, we tend to use low molecular weight heparin during pregnancy. And then what about subsequent pregnancy? So mum gets through pregnancy, has a healthy baby, hopefully, and we see an improvement in pump function. What next? Often mums want more than one baby, and sometimes we have to have difficult conversations about that. I think the truth is you have to take every person on individual merits, and I think a lot of the pregnancy team at Birmingham do a lot of work risk stratifying people and trying to decide what's the right thing for that individual. And we do quite a lot of tests, but essentially we will, obviously those patients in whom the ventricular function recovers, so an LVF of greater than more than 50%, tend to do better as a general rule, and those are more encouraging. But even in that group, and I think it's important to stress that, just because the heart pump recovers doesn't mean you still have a normal heart. And 1 in 5 of those individuals will still have a relapse. And if you have a severe deterioration, although that's rare, that does carry risk. So we have to be really careful, because if mum's not well, then the baby certainly won't be well during pregnancy. So we have to have some difficult conversations around that sometimes. Medications, obviously, we've talked about already. In those patients that haven't recovered pump function and then become pregnant, those are the patients we're most worried about for obvious reasons. And those patients tend to be at the highest risk. This is hot off the press, actually. This was a paper that was published only this month in JACC, and it shows you that there's quite a lot of interest in this area because it's not terribly well researched, at least peripartum cardiomyopathy. So this was a small study, only 45 patients. It was a US-based study. 80% of all patients were Black, from African American descent. So it's probably not that representative of all populations, but nonetheless, it was slightly alarming in that even in those patients that had normalization of heart pump function, that didn't guarantee always a favorable outcome. So I think the important thing is to take this seriously. And I think if patients are contemplating getting pregnant again, having already had 1 episode of peripartum cardiomyopathy, they do need to think carefully, be seen by the right people, and have some careful, ideally, risk stratification prior to contemplating a further pregnancy. That's far better if we do it that way. The advantage that gives you, for example, in the patients where we've done that, is that we can withdraw the ACE inhibitor and the angiotensin receptor blocker or Entresto beforehand, repeat the echo, do an exercise treadmill test, give us an idea about whether that individual will then get through a pregnancy, and then can have some more meaningful discussions. But that's far preferable to patients pitching up telling us that they're 2 or 3 months pregnant, which I don't think any of you on this chat would do, but trust me, that's not uncommon, and not an uncommon occurrence in our practice. So my main take-home message really, and this was a fairly general talk, but I think it's really important. I mean, my love and my interest is in patients with inherited heart muscle conditions, and I've increasingly diagnosing patients with familial forms of dilated cardiomyopathy who were initially diagnosed as having peripartum cardiomyopathy. So I think having your wits about you as a clinician, but even as a patient as well, and having a low threshold to explore DCM genotyping, because based on these reports, probably as many as 1 in 7 patients who present with a peripartum cardiomyopathy may have a familial form of that condition. In other words, they may have a genetic typing error that's contributed to their condition. Hopefully, I've stressed to you the importance of pre-pregnancy counselling and involving your cardiologists in discussions around pregnancy earlier. I don't think all cardiologists are as good as they could be about having those discussions. And lastly, Lucy Hudsmith would kill me if I didn't mention contraception in this talk. So I think the forms of contraception we would tend to recommend are progesterone releasing only forms. So that would be subcutaneous implants or the Mirena coil, and generally combined oral contraceptives that contain estrogen tend to be avoided because have slightly higher risk of clots. So fairly whistle-stop tour, and I'd be delighted to take any questions around that, and hopefully that's been of some interest.